medicine can be kind of confusing. It's confusing, and it's kind of irrational sometimes. I like to tell people, we think we're so we're technologically advanced in medicine, but a lot of this stuff is we're still kind of in the dark ages with a lot of it,
Hello, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is a dear friend, Dr. Joe McGreevy. Welcome to the show, Joe.
Thanks for having me.
Joe is an internist. He's trained in internal medicine, and right now you're currently working at Boone Health Center as a hospitalist.
Yes.
Now, Joe has wide-ranging interests, and a couple of them have really caught my eye, Joe, and I think it can be very valuable to our audience. You have some thoughts about the field of longevity, and I think we're going to hit longevity at the second half of this discussion. And you also have some thoughts that I think will be very valuable to our listeners about navigating the medical world. It's very hard. How does a normally, regularly intelligent person navigate this incredibly confusing world of medicine? I mean, you can be smart, but how do you get through understanding tests and procedures and how to make decisions and who do you go to? And it's an enormous topic that I think almost anyone who's a civilian, who's not a doctor or a nurse or a medical professional, would really benefit from learning about. If we have some time, I'd like to talk about how doctors make a diagnosis. It's something I don't think gets enough attention. And we can talk about medical testing and whatnot. So we have a lot of things to talk about, Joe. Yeah. So why don't we talk about navigating the medical world?
Sure.
Tell us your thoughts about that, please.
Yeah, when I think up that, that sort of catchphrase there, I spend a lot of time online, reading various websites, message boards, Reddit, namely. A lot of times I see people post, a Reddit thread or something, talking about how they visited their doctor and, it seems like a common thing is like, somebody goes to visit their doctor, maybe that may be an emergency room visit, and they leave the emergency room visit or their doctor, and they're just like, well, what happened?
What just happened? Right.
I went in for, a belly pain, and then I came out and maybe I got a prescription, maybe I didn't. There were some tests, and then, you walk out the door and then with maybe a diagnosis, and that can be just a very kind of confusing and
or even situation. Worse, go see your doctor tomorrow. Yeah, make an appointment with your doctor.
Yeah.
It's like, I just spent $6,000 for that.
Exactly.
Right.
Yeah. And so, that's when I say navigating the medical world, that's kind of what I think there's a lot of, it's kind of like setting expectations. It's like, if somebody has a little bit of a look kind of behind the scenes of, what actually happened during that emergency room visit, or what does the doctor mean when they say, it could be this, a set of five, maybe five different things, and when they get a CAT scan and that, that's negative, what all does that mean? So that's kind of what I've, when I use that phrase, that's kind of what I'm talking about, to try to educate the public, educate people, just to be a little bit more well-versed about, what happens when they go to the doctor or ER visit or whatever.
Yeah. So let's say you go, and by the way, reminds me of a Seinfeld episode where George, the hypochondriac, he hangs up at the doctor's office, he starts crying. And they say, why are you crying? He says, all my tests are negative. Meaning bad. He thinks that's bad. But negative means they didn't find anything, which is generally good.
Yeah.
So a negative CAT scan means normal.
Yeah.
It's not a bad thing.
I often, that reminds me, occasionally when I have a patient encounter in the hospital, I oftentimes kind of present the opposite of that. It's like, well, I kind of got good news. We found something, and it's not
Right.
It's like, because oftentimes, somebody's there for, what's a serious issue, and it's like, and we don't know what's going on. But if we found something very specific, it might not be, maybe an infection, bacteremia or something. Those are serious things. But at the same time, we found something that's explaining your symptoms. And, most of the time those things are treatable. So, it's maybe not good news, but, like a silver lining sort of thing.
Yeah,
So,
I explain it. I say, Mrs. Smith, I found something and it's actionable. I found the likely cause of the problem, and there's something we can do about it.
Yep.
Which is good news, right?
Yeah, I use that same word, that's
actionable.
Yep.
Right. So help a person who's listening to this podcast navigate the medical world. Let's say they have a problem and they're going to their doctor.
Mm-hmm.
Or is there a general rule of thumb or a formula so you can ask the right questions and make the visit as productive as possible? What advice do you have, perhaps?
Yeah, there's a lot of different things somebody could do. One is just kind of getting an idea of, getting an understanding of how is the doctor thinking, how is the doctor kind of integrating this information and using it to try to come up with a differential diagnosis or a set of diagnoses, possible outcomes here. And one of those is really trying to focus on a chief complaint. That's a word we use really to kind of describe really the most salient or most worst or most obvious symptom that somebody might have.
Right. Now, and this is another word. I had patients say, the doctor, to get their records, and they say, they said I was complaining.
Yeah.
It's like, no, a complaint doesn't mean you're complaining. A chief complaint means what's bringing you in here. Gee, my head hurts, or gee, my hand is swelling, is a chief complaint. It's not an insult. They're not calling you a complainer. All right. So your top issues.
Yeah. Top issues. I often struggle with a way to put that, because we all use the word chief complaint, and when I'm presenting it to a patient, I rarely ever actually use that word.
Yeah.
But it starts with that really, because when a doctor is trying to figure out what's going on with somebody, really it's easiest, might be the best way to put it, if we can figure out the most obvious symptom. If somebody has maybe nausea, vomiting, and abdominal pain, really the abdominal pain is going to be the most specific symptom that they can target to try to do their exam, and then focus on tests to try to figure out what that is.
So maybe a patient can help the doctor by being to the point, right?
Yeah.
Say, well, my grandma called, then I was walking up here, and then I thought this, and then maybe it was this. And I thought it was this. It's better to say, I had a headache at 2 p.m. in this part of my temple, right?
Yeah. Yeah. And, it can be hard, because when a patient or when we experience a symptom or something, it's very rare that, we're going about our day feeling like our normal selves, and then suddenly we get a sudden onset of belly pain, and then it started 5 hours ago and it's been this long. Oftentimes it's, I don't feel that good. What does good mean? That's one thing. And then it's maybe abdominal pain or belly pain kind of creeps up on somebody, and it's kind of this subtle thing that kind of develops over time. So it's hard to put a specific time on it. And I think about that myself, every now and then, you get little cramps or something like that. Everybody experiences
Something's
that.
Not quite right.
Yeah. And I think about it myself, it's like, okay, if I was trying to describe a belly cramp that I'm having, how would I describe it to a doctor? And I kind of go through this sort of thought experiment to try to just try to understand, how a patient might be trying to explain it to somebody, and oftentimes if you have a cramp or something, it's a belly cramp, it's kind of hard to say, that started 2 hours ago, to really kind of describe it really specifically how a doctor would.
It's tough, and a person will say, my stomach hurts, and you and I know the stomach is here, and somebody's down here in their tummy, and they say, my stomach hurts. nowhere near the stomach. So we have to learn how to translate these things.
Yep. And that gets into a whole other issue there is that, really the practice of medicine, it's all about communication. And it's like, I feel like as a doctor, we actually become masters almost of just being able to communicate with people, figuring out how people communicate and trying to interpret what somebody else is saying.
Well, the good doctors get good at communicating. Yeah.
Because it's just like you said with belly pain, a common thing that I encounter is one person's pain is another person's, well, it just hurts. Pain and hurts might not mean the same thing to certain people. And I encounter that quite a bit where chest pain's a very specific thing that's, we see often in the hospital that we have to kind of differentiate and figure out what's going on. And I frequently will encounter a patient. I say, well, when did your chest pain start? As I have read the admission note and I see it says chief complaint, chest pain. And so the first time I pick up the patient and meet them, I might say, when did your chest pain start? And they say, well, I didn't have pain. I had pressure. And it's it's like a lost in translation sort of thing that you have to, so there's that element of it to just making sure that, the patient and you are both talking about the same thing.
Yeah.
And that can be a difficult thing to navigate every now and then.
And there's different types of pressure. There's a little push, and then there's the 6-ton elephant sitting on my chest pressure.
Yeah.
So,
kind of this, kind of tying it together with this navigating the medical system. We've talked about a chief complaint, but we've also talked about kind of nuanced, things that can affect, what a chief complaint is. What doctors really try to do is they try to isolate that chief complaint, chest pain or abdominal pain. And that kind of is like a feeder, you can think of it as like a algorithm, so to speak. If somebody has chest pain, then I need to be thinking about, maybe these 5 diagnoses that can cause the most harm or, morbidity and mortality for somebody. And that, that's kind of how doctors kind of break it down. And then, if getting like say chest pain or abdominal pain, that helps kind of direct you towards organ systems and areas of the body that could be affected that kind of directs you where your diagnostic pathway is going to go.
So maybe something that would help someone in general navigate the medical system, is kind of maybe organize your thoughts for a couple seconds. Gee, when did this start? Has it ever happened before? How long has this been happening? Did I do something to make it worse, or did I do something to make it better?
Yeah.
Because that's what the doctors think on the other end.
Yeah.
That's what they teach the medical students. How long, duration, that kind of stuff. So you can kind of maybe organize your thoughts to maybe fit into that algorithm a little more cleanly, right?
Yeah, that's a good way you described it. And that is, we have this thing called a H&P, or a history and physical, or an admission note. It kind of has several different names, but you just kind of went through the primary things that when a physician first meets somebody, a new patient, they kind of identify this chief complaint, chest pain, and then they kind of go through these set things to help describe the chest pain and its qualities. Like you said, the location. It's in the middle of my chest. Duration, or when did it start? It started 5 hours ago. What were you doing when it started? Well, I was running around the track when it started.
Right.
So what made it worse? Does running make it worse? Yes. What makes it better? Did sitting down and resting make it better? And then the last part of that is kind of any associated factors. So were you sweaty when this chest pain came on? Did you have shortness of breath associated with it? Did you have a cough? Do you have a fever? And all these questions, they kind of, medicine is probabilistic. General medicine is probabilistic, and it's very rare that we can, at least in general medicine, hospital medicine, it's very rare that we can get to a point where we're, any diagnosis is really 100%. It's very rare that we can be 100% certain on any diagnosis.
Yeah, let's clarify that, Joe.
Yeah.
Sometimes when I'm treating patients, I say it's kind of like playing poker.
Yeah,
You've
exactly.
got you play the bet, you play at the bet. There is a perfect way to play poker, but it's still percentages.
Yep.
If it's a 72% chance you're going to win, you're going to play it. But sometimes you're going to lose just because there's that, whatever the number, 28%, it's not going to work, right? And you get what's called a bad beat. You do everything right and it still doesn't work.
Yep.
And then you can get lucky. In hearts, it's called shoot the moon. You lose every hand, and all of a sudden you lost, but you won. So sometimes you can just get lucky. So people need to realize that there's probabilities in medicine. And I find when I'm counseling people, I'm throwing all these percentages around, and not because I just want to sound smart, because I want to give them some idea of likelihood.
Yeah.
Of having a problem. So people need to understand it's rare. Now, obviously, you get cut and you need stitches. It's 100%. You have a laceration that needs stitches. I mean, there are black and white situations.
I'm glad you brought that up, because that's I play a little bit of poker myself, and so it's not to. I think about it in those terms a lot. It's not to kind of equate health with gambling, but at the same time, card playing and that probabilistic nature of poker, it really describes general medicine really well. Like you said, if you cut your arm, or think something I like to think about is like if you break a hip, there's no equivocation about that.
Yeah, broken hip needs orthopod.
Yeah, you can
fix
see
it.
that. Yep. And so, one example I occasionally bring out, when I'm talking to patients is like, we might throw around things like, well, in this certain context, you have like a 95% chance or probability or chance of getting better, responding treatment, or not. But then, I feel like those words, or the 95% chance, can kind of fool people sometime.
Mm-hmm.
Getting back to the poker analogy, something I think about is, if you're playing Texas Hold'em poker and you're heads up with somebody and you have an ace in your hand, if you go all in pre-flop, I'm using a lot of poker lingo here, but you have an 85% chance of winning that hand. 85% chance
with bullets.
Yeah,
they're called bullets.
However, if anybody's played poker long enough, I'm sure everybody has had that hand and lost, and still lost.
15% of the time, maybe.
I've had that hand. I can remember, I got into online poker several years ago, and I can remember there was this time when I was playing for a week or so, and I had 5 times in a row where I lost, heads up with aces and pocket aces. So that I think about that a lot when you think about these probabilities. And what is 95% chance of having this? What does that 85% chance really mean? It means if you played 1 million hands over time, then that would be borne out with the probability. So I bring that up just to say we can do everything right in medicine. The tests can all point in a certain direction and say this is the diagnosis based off these tests, but at the same time, because it's probabilistic in nature, every now and then it's tests aren't going to be right.
Yeah, so let's go into that. So let me summarize what we've got here so far to help somebody navigate the medical world. Put your thoughts together and try to get your symptoms or your complaints into some kind of organized statement, let's say. So go to the doctor, be honest with the doctor, right? Tell them all your medicines, all right? I can't tell you how often, after the 3rd or 4th or 5th time talking to somebody, they'll say, oh yeah, I started taking blah, blah, blah. It's like, why didn't you tell? My nurse asked you that question. You said no, and my student asked you that question, and now you remember. So that would be nice to get all that information out and be real honest with. So that will help your doctor, your practitioner, let's say. And then there's the getting tests. Frequently they're blood tests. There's other tests, X-rays, imaging studies are called. So let's talk about this huge topic. I'm going to start here. A lot of blood tests are based in what's called a normal range. I have a lady in the hospital right now with low sodium. Okay. A normal sodium is 135 to 145, let's say.
Sure.
Right? And so people understand, that's a bell-shaped curve, okay? The average is about 140, and then it decreases a little down the sides of the bell curve, and we have decided that at about 135 and below, that's so many deviations from the average, and above, that's abnormal on a statistical basis. But what does that mean in the real world, right? So you have to turn this probability, but is it really, if normal's 135 and my lady's 134, is that abnormal? Is that really abnormal? So talk to me a little bit about, and another thing, if normal is within what are called 2 standard deviations, which means 5% of the time something's going to be out of the normal range just by chance, right?
Yeah.
So if you order 20 tests on somebody, chances are one of them is going to be abnormal,
Right.
but it's not abnormal.
Yeah.
So can you help us with these concepts, Joe? What are your thoughts on statistical distribution, normality, probabilities? Help us interpret blood tests.
Yeah, I try to tell patients that when we think about medical tests, medical tests aren't a light switch. It's not an on or an off. It's not a binary. It's not a 1 or a 0. It's it can mean a spectrum of possibilities, given in the right clinical context, and so, getting to the part about reference ranges, these reference ranges, it's been a while since I read about them, but from what I recall, they're, it's like thousands of people that you check, the sodium's on 1,000 people, and it's you call this 1,000 people normal,
Right.
and then you see, well, what's the 95% range of confidence interval range of those 1,000 people that were normal, and
Right.
so you can still have, just because the test is abnormal or outside of that range doesn't necessarily mean that the patient in front of you, or if their sodium was outside of that range, it doesn't necessarily mean that their test is abnormal, So you always have to relate a test associated with the patient, in residency. My attendings would always say, the patient will tell you everything you need to know. And, it always goes back to the patient. So you always have to interpret these tests within the context of what the patient is giving you,
Right, so that assumes the doctor has time
Sure.
to listen. The patient is awake and communicating.
Sure.
There's an honest interaction
Sure.
going on. And the caregiver has, isn't having a bad day.
Yeah.
Right? Very good. Very good.
Yep.
Another thing about testing that drives me crazy, Joe, is these cholesterol levels. First of all, most cholesterol is bull dinky, all right? It's not nearly as important as people make it out to be. A normal cholesterol is less than 200. So a person gets a cholesterol of 201.
Yeah.
The non-thinking computer puts a big red H,
Yep.
201, high, abnormal. And people freak out and start giving statins and all this stuff for 201. Just because there's an H on there, right?
Yep.
So a computer isn't going to look at the person or the context. It's just going to mindlessly label something as abnormal. So
Yeah.
you don't want to overinterpret these things either, do
Yeah.
we?
Yeah. So it's with your example of, a cholesterol 201 in a 25-year-old that's a marathon runner, it probably isn't going to mean much, and
it's meaningless.
cholesterol like that in a 45-year-old obese diabetic, you would probably want to treat that, but
Maybe. That's a whole I shouldn't
Yeah.
have brought up the cholesterol because it gets my blood pressure up because it's been so overplayed.
Yeah.
But the concept is, you got to put it in context.
Yeah.
And that's where having an honest communication is really important.
Yeah.
Right? Like you mentioned the person who goes to the emergency room and leaves not understanding, right?
Mm-hmm.
The emergency room doctor's just going to make sure you're not dying,
Right.
right?
Yeah.
You're not going to die in the parking lot on the way out. and you're safe, right?
Yeah.
And haven't communicated with you or told you what you might have. So, okay. So you see the doctor, you tell them what's going on, they get some tests. Then what happens, Joe? How would you help a person navigate the next thing? So the doctor comes back and says, I think you've got blah, 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 for example. So what's a patient to do then? Here in the Midwest, everybody's really polite. Mm-hmm. And they don't want to seem rude, like they're questioning the doctor or they're asking questions. Now, in New Jersey, where I'm from, what do you mean? What do you mean? My Aunt Stella over here said this, or I read this, and blah blah blah. They don't have any. Maybe there might be like a completely different attitude. So, how do you advise a person who's got some test results back to interact with their caregiver?
Yeah, with some of what you were talking about, questioning the physician, or asking about your medical tests, I try to tell people, I support all of your questions. I support questioning me, I support, everything you're doing because, kind of getting back to this idea of, probability, medicine is probabilistic and, it's just the fact of the matter, while I like to think I'm a pretty good physician, at the same time, probability dictates that sometimes, what I think is going on with somebody might not be right, Yeah. And so I support a patient, asking about their labs and checking on things. With what you said, it made me think of a patient that, I would go in there and talk to them about their labs. So I'm a hospitalist, so I see people daily. So I kind of have this daily track with somebody, and I would go in there one day, talk about some of their labs, the day would go on. And then the next day they would say, well, I looked up online, everything we talked about yesterday, and they have the patient portal so they can see their own labs. So I looked at all. So I looked up all my own labs and checked, all this stuff. And I told the person, what, I support you doing that. You're
because you're confident, Joe. Mm-hmm. You're confident in yourself. And you're smart, and you care, and that doesn't threaten you. Correct?
Yeah. Well, and it's what I try to tell people too is a patient knows their own body. You're going to know your own body and your own health.
Usually,
hopefully, in a way that I or any other physician is never going to be able to know. I could take the best history and best exam ever done in the history of mankind, but there's going to be an element of subjectivity, objectivity that no doctor is going to be able to bridge that gap. So, certain things, getting back to this kind of chief complaint thing, certain things, certain things are difficult to describe, like the symptom of fatigue, how does that really feel like, so,
right.
So getting back to the labs and stuff, I support somebody looking that up because they might be looking something up on their phone that they just can't really quite don't know how to quite describe it to a physician, and then looking up on the phone they might see something that, then stokes a conversation with the physician. And I try to counsel patients on just, don't hang your hat on anything you find online, but if you find something you're interested in, you're always welcome to talk to me and we can kind of figure it out.
All right. So I think that's a rule of thumb, Joe. Patients should not be afraid to ask questions. Mm-hmm. A respectful, thoughtful question should always be answered and responded to by the practitioner, by the provider, right?
Yeah. Always.
That's our job.
Yeah.
Right. And if you feel that you can't ask questions of your provider, granted, sometimes you don't have a choice. You're in the emergency room, and that's where you're stuck, right?
Yeah.
But given the option, you should seek out practitioners who will talk to you and answer your questions, right?
Yeah. And I know, it can earlier on in my career, when a patient would answer questions like that, I would get a little defensive, sometimes,
Sure.
and it can also depend on, whether I'm hungry, hangry or hungry,
Right,
so
right.
it's all these things, we're all human. And so it can really, sometimes it can affect, how you respond to some of these questions.
It's called HALT. Hungry,
Right.
angry, lonely, and tired.
Yeah.
And your doctor
Yeah.
can have a HALT, something in his HALT be off. Yeah.
So, at the same time, I support a patient, anybody looking up their own medical issues online and talking about it, and as a physician, we need to try to have that patience to try to be able to talk to somebody about it.
Good. So we're in agreement on that. So let's talk about how a doctor is making a diagnosis.
Yeah.
Now you have a concept called that you bring into this. It's a word called ontology. It's the relationships between various things and their connections that we use to make decisions.
Yeah.
So tell us a little bit about how doctors make decisions, but all this information, disparate information. In fact, something is an X-ray, something is a blood test, something is a history, something is running in your family.
Yeah.
How do doctors put this together to make a diagnosis? Can you explain that?
And so, when this ontology, a medical diagnosis, part of that word ontology, part of its meaning, and this is kind of a concept that it's a work in progress, so this,
Sure.
But, part of that word is the to exist or to be, or what does it mean for something to exist? And what I mean by that when I'm talking about medical diagnoses is, a medical diagnosis oftentimes is contrived. It's a defined sort of defined sort of criteria that we give it credence because the Infectious Disease Society of America or something says, oh, this is what a UTI is when you have symptoms plus laboratory abnormalities in the right context. That's what a UTI is. It's as opposed to, an analogy I give is like a car. A car is engineered by humans. We know everything about a car and how it works.
Yeah.
And say if you try to go start your car, maybe the engine doesn't turn, lights don't come on, so that gives you a chief complaint. And, then you have a set of possibilities when the lights don't come on. Maybe it's the battery, maybe it's the fuel pump, something like that.
And a good mechanic can figure that out.
You pop open the hood and see that the red terminal is off your battery. You put it back on. About the closest you can get to that analogy with medicine is what we were talking about with like a hip fracture.
Orthopods.
Like,
that's why we tease orthopods.
Right.
Never miss an opportunity to tease an orthopod.
Right.
We tease
I remember in medical school, I can remember a orthopedist gave us a lecture, and I forget exactly how the joke went. He said something about the heart. He said that's what pumps blood or pumps the antibiotics out to the joints. So, I love that. But
that's great.
With a lot of medical diagnosis, they don't have that. And so like the complete opposite of that is this UTI. This example is, and so I kind of bring this example up because most people, even if you're not in medicine or healthcare, have probably experienced the grandparent or the older, UTIs, the emergency room visit for their grandparent that's a little bit confused. They go to the emergency room, done a battery of tests for the emergency room doctor to come in and say, well, it's a UTI,
Right.
But there's a lot more to the story than that. It's oftentimes a UTI, there's this thing called asymptomatic bacteriuria where, oftentimes we hang our hat on something being a UTI because we can check somebody's urine, we culture the urine, and maybe there's E. coli in the urine.
There's some bacteria in there, but is that really the problem?
Right.
Low level, you're older, you've been living with it.
Right. And it just so happens that we have a pee hole next to a hole that
a poo hole.
A poo hole. So and that lends itself to E. coli is in our stool, and that lends itself to every time you culture E. coli in somebody's urine, it's not a UTI.
Right.
So that kind of what I'm trying to describe here is in essence what I get to what I'm trying to describe with the ontology of medical diagnosis. You know, a UTI is like to try to get down to what does it mean for a medical diagnosis to exist. You know, you get down to, you know, what is the fundamental thing that's fundamental thing that drives the diagnosis. You know, a UTI, you know, a best example is like a cancer. You know, there's a cancer is oftentimes based off a biopsy. You know, you take a biopsy, you look at it under the microscope. There's no equivocation about that. There's cancer. You know, you don't really have that with a UTI. Same sort of thing.
Okay.
And so, you know, I think that this sort of concept it provides. I think that's a source of a lot of confusion for people when they go to the hospital or go to the emergency room, because like we said in the beginning, it's like you go to the emergency room and then, you know, you oftentimes maybe they did a battery of tests and then you leave and somebody's like, but I don't know what happened, you know?
Right.
And I think that this concept that I'm talking about, I feel like it's kind of the crux of where there's a lot of confusion in the patient's mind, you know, and the patient and the public's mind regarding a medical diagnosis. And even with the COVID pandemic, you know, some of all the confusion that was surrounding the COVID pandemic kind of gets back to some of this too, because it's like, you know, we talked about people that were dying in the ICUs of COVID, but sometimes maybe they tested positive for COVID 2 weeks ago, but now they're on a ventilator. And they have hypoxic respiratory failure and you know, and they passed away, you know.
Okay.
So then, you know, people can look at that situation and say, well, they didn't have COVID now, so why did it seems kind of ripe for people to say, well, there's something confusing going on here.
So the insult, the lung damage was COVID. Being on the ventilator was damaging. And even though they don't test positive for COVID right now, you can call it a COVID death. That can be confusing.
Yeah. And, yeah, you know, and the whole, I mean, I don't necessarily didn't mean to get on a tangent with COVID, but the whole COVID pandemic, there was a lot of confusion in that whole time, and a lot of it was like stuff that's just hard to explain to the public as a physician, unless you kind of experienced it, you know, as a physician, you know.
Sure.
And it was, you know, working in the ICU during the COVID pandemic. You know, there was like a phenotype with COVID where nobody could explain it, but it was almost to the T. Somebody would get COVID and then they would present 2 weeks later, and then they would be on a ventilator, or they would have hypoxic respiratory failure and need to be on a ventilator.
And a phenotype is the outward expression of something. If somebody's overweight, high blood pressure, how you're manifesting on the outside. So it may be a way to describe phenotype.
Yeah. But I just, you know, I guess my point with this whole tangent here is really just to say medicine can be kind of confusing. It's confusing, you know, and it's kind of irrational sometimes. And, you know, sometimes there's not a great way to make heads or tails of this. You know, you go to the emergency room, do a battery of tests, and then, you know, grandma's got a UTI. You know, sometimes it can be kind of bewildering for people, and you know, I like to tell people, you know, we think we're so medically or we're technologically advanced in medicine, but a lot of this stuff is we're still kind of in the dark ages with a lot of it, you know. And
realize if the doctor is 80% sure, they're still going to write a prescription because they want to give you a prescription, make it seem black and white, and get you out of the emergency room.
Well, that's a difficult part about it too, because this stuff is kind of hard to communicate in a way that's understandable, you know, to a patient that may not know that medicine's probabilistic and the medical tests aren't, you know, black or white and all this sort of stuff. And so you have to kind of distill, as a physician, you have to kind of distill the information down to a patient in a way that that's understandable. So the easiest way to do that is to go into the patient's room and say you have a UTI,
Right.
as opposed to going into the patient's room and saying, well, there's maybe 60% chance this is a UTI, and
Not
nothing else.
satisfying.
Yeah, and nothing else is coming up positive. We know it's not a stroke, a
Right.
brain bleed, a heart attack, all this other stuff. So we're going to try giving you an antibiotic for 5 days and see if it gets better,
Yeah, and realize that your different doctors in different situations are going to have different priorities. I'm going to bring up the emergency room again.
Mm-hmm.
They just want to make sure you're not dying,
Yeah.
right? Or
Yeah.
your cut is stitched up and boom. There's a joke I'm going to tell, Joe. Say, how do you drive an emergency room doctor crazy? Tell them you're tired and weak all over. It's non-specific. It's a time, to place, to diagnosis. They want something, broken bone, gonna fix it. Appendicitis, call surgery, take it out. That's what they want. But whereas if you go into a family doctor, maybe they have a little more time, or there's room, there's wiggle room or whatnot, right? Very, very difficult. So not easy negotiating. Labs aren't perfect. Diagnoses are perfect. And before we move on, Joe, I want to make just another observation. When doctors make a diagnosis, it goes on the forms, goes to the insurance company makes a payment due to how much time you spend, how complex was, right, the work or what have you, right? No, this is going to stun most people. No one checks to see if the diagnosis was correct. There is nobody, there's no Uber supreme doctor saying your diagnosis was right, your diagnosis is wrong. The diagnosis is made, treatments are done, payments are made, and nobody checks.
Yeah.
Now, since I'm a reproductive endocrinologist, I deal with rare, let's say esoteric or diagnoses of hormones or genetics or something. These are fairly rare, right? And I see people come in with these weird diagnoses that are wrong.
Yeah.
Right?
Oh, I'm sure.
They're wrong. But no one's ever checked to see who was right. So there is at some level, there's really no check or balance. We don't have time to go back and check all these diagnoses. Now, in medical school, academic places, you might do chart reviews, or there might be some inspection, or sometimes you're looking at a hospital statistics. You'll go, show me all your hip fractures for the past 2 years or something, right? But that might horrify people, that diagnoses are not checked, and bad doctors can be inaccurate, and there's no check on it.
Yeah. That's that kind of, that really gets into what I'm been trying to talk about, the last several minutes about all this medical diagnosis and ontology and all this sort of stuff. It's a medicine's opinion. Ultimately, the foundation of it is that at the end of the day, the diagnosis that a physician comes up really is the opinion of that doctor, given the clinical context, the objective, hopefully based off of some objective data. And, it ultimately comes down to the doctor's opinion,
And when you want for a second opinion, you are getting a second opinion.
Yeah, exactly. That comes up a lot. Patients ask, what do you think about a second opinion? And, getting back to this, patients kind of reading about their diagnosis and stuff on the phone. It's like, I 100% support you going to get a second opinion,
and I qualify this, Joe. I love second opinions. But from a smart doctor, there's nothing wrong. There's nothing worse than a second opinion from an idiot.
Sure.
And they are out there.
Yeah.
And I usually have names of people or places that I respect. And I say, I would really, and I say, there's some places I love to send people to certain places because I know they're going to get a good second opinion.
Sure.
Right.
I can imagine that as a internist, more a generalist. That I don't encounter that often, but I can imagine as a specialist that that can be a pretty big issue, because then you have to kind of, if somebody comes back to you with a second opinion, then you have to kind of walk them back from it.
Got to walk them back, or they come say, "Oh, you were wrong." It's like, no, my friend, I was not wrong. Anyway. I'd like to shift gears, Joe.
Sure.
Completely different subject. Let's talk about longevity. Obviously, longevity is linked to health, but it's a particular aspect or facet of health that gets a lot of attention, gets a lot of fringe medicine, let's say, notions and potions, and talk about opinions, right?
Sure.
Ray Kurzweil was interviewed by Bill Maher the other day. Ray Kurzweil, smart guy. And by the way, he looked a lot older. Ray is this really smart guy. He's been a thought leader. And he's been talking about the singularity, where if eventually our minds and the computers and the artificial intelligence are going to merge at some point. And once you get that, once you're on the machine, once you're on the cloud, once Joe is on the cloud, you could live forever, right? And what does that mean and whatnot? And I believe he or people in that world, you're talking about all these different supplements and things you can do to maybe live longer and whatnot. So with that, start on the conversation, Joe. Talk to us. What are your feelings about longevity?
Yeah.
What can we do about it? What's out there that's exciting?
Yeah. I think, when it comes to longevity, it seems there's a lot of, it's interesting to read about all the new research and these new supplements and new things that are coming out, and resveratrol does this and this NMN thing does this. But
all right, resveratrol in red wine and grapes, right?
Yes.
And MSM, what is that?
NMN.
NMN,
That's the one that I think it's David Sinclair has. He's actually the same guy that did resveratrol. I think it's a Harvard lab that kind of discovered these things, and I think they do studies in mice that show that that the mice live longer with them,
right?
Or they have benefits from it. These are two supplements that people talk about. When it comes to longevity, though, I think I like to keep it simple. And I think the best thing, if somebody's interested in longevity, the first thing somebody should do is just try to live their healthy life. So if somebody is the best thing anybody can do for their longevity, aside from these supplements, if somebody's obese, if they're smoking, if
diabetic, these the obvious ones. All right,
right.
So we're not gonna make it seem super. That's not super sexy.
It's not.
It would be nicer just to take a pill and live forever with quality of life.
Right.
Obviously, we don't want to be.
We talk about this health span and lifespan. Health span is kind of the idea of how much time do you have to live that's good quality, healthy life.
That's
and then
good point.
Lifespan is this idea of basically how long do you have to live where you're basically a pulse and breathing.
Right. You're still warm.
Right. So, and I think you're right. It's not sexy, but at the same time, just do the simple things first, and I think and I say that because it's something that anybody can do. These NMN, it's kind of been a while since I read about it, but some of these supplements can get kind of expensive, and I think the NMN is also, there's no oral formulation of it, so then you got to deal with subcutaneous injections or something. But it's like the easy things to do, if you're obese or you smoke or diabetic, get these things in order first. And these are the things that are going to really, truly, really impact your health span, over just taking, NMN or something. And with that, one of these kind of more trendy things is the intermittent fasting, that had been really popular a few years ago. I think this David Sinclair scientist he was one of the proponents of it too. He had done these studies in mice that showed the
you starve fasting. The mice, you get like 30% longer
and
lifespan,
I think intermittent fasting is, I really I think there's some elegance to it in that the way it's described is like when we were 10,000 years ago nomadic, and it's like when we didn't have food, that's really when we had to perform at our highest levels. And so so the high theory with this intermittent fasting is that when you're in a fasted state, you're catecholamines increase, you're going to feel a little bit more energetic because, evolutionarily you have to go out there and find the food and get the food.
Right.
And the intermittent fasting too is something that, doesn't cost anything. It actually might cost a little bit less,
Right.
And it's something that easy to do that I talk to patients about. Something I talk to patients about is just a 24-hour day, a 16-8 fast, where you fast.
Yeah, Joe, I see it. So I get blasted with ads
Yeah.
on my various social media and said, because they know how old I am.
Sure.
All right. In fact, they probably
Sure.
know everything about
Sure.
us at this
Yeah.
point, right? And they say, well, a man in his 60s should, you can go so many hours here. It's like, is there any data that at 63 I should fast for so many or not eat for so many hours versus when I was 42? Is there data on this that you're aware of?
Well, I know that there was specifically on that question, I'm not sure. I know that with intermittent fasting, it's kind of unfortunate that there was recently an article, I'm forgetting which journal it was. I think it was JAMA or, one of their subsidiary journals, where they released it was within the last 3 months. They released a pretty significant article. I think it was a retrospective cohort study. I think there was to the tune of, tens of thousands of people in the study. And it actually showed that intermittent fasting, I put it in air quotes because of the way they did the study, but it showed that intermittent fasting actually had worse cardiovascular benefit, worse health outcomes. And I say it's rather unfortunate because I think it was a little bit, irresponsible to release that study, because if you read the methods in it, the way they define this intermittent fasting is, they sent out a questionnaire.
Right.
There
you go. It's worthless.
It was literally, asking, over the past 12 months, do you think that you ate only 8 hours of the day? And it was,
yeah.
So
these are almost worthless, folks. Yeah. People don't recall what they actually did.
Yeah.
There's bias in that and whatnot.
When I think about the data for intermittent fasting, it's not the highest quality data, but there's a researcher, I think his name's Dr. Fung, where he has a case series of 10 or 12 patients, and he followed them for 6 months, and they were all diabetics on about an average of 100 units of insulin a day, and they did this the 16-8 fast, and they would supplement it with a 24-hour fast at the end of the week. And in a month, I think it was something like 50% of those patients in that case series, they were completely off their insulin in a month.
Right. Yeah.
So
that's exciting.
I talk to patients about this every now and then, about diabetes in particular, because, as an internist, I think every internist will get a sense of treating a diabetic, and that over time, the insulin dose just keeps getting worse and worse. You have to increase the insulin dose over time. Over a period of 5 years, if somebody starts on 10 units of insulin a day, at the end of the 5 years, they might be needing 40 units of insulin a day. And if you think about it in that way, if the insulin dose is increasing, as a doctor, you're making the diabetes worse in a way. You're increasing their insulin resistance. They might have an A1C of 7.5, and so their cardiovascular risk is improved, but at the same time, you're kind of technically worsening their diabetes over time. So the real treatment for it is, this intermittent fasting. And this Dr. Fung with this case series, they were completely off insulin after a month. And so, you talk about health benefits, that's why I say it was kind of irresponsible for this study where it says it's worse cardiovascular benefits, because it's almost like so obvious that if you have people that are diabetics on insulin and then suddenly they don't need insulin and they're kind of not diabetics anymore, it's almost so obvious that their cardiovascular risk is going to be much lower. Their mortality is going to be much lower. So, that's.
And I'm afraid that article is probably it's based on mathematical associations. It's an association, and it was called partitioning of variance, and there's no causality at all. It's not like one thing caused another. There has been some buzz, Joe, about a medicine called rapamycin.
Yeah.
In the fertility world, it's getting some interesting play because women during their reproductive lifespans run out of eggs every day. Women are born with a certain number of eggs. Every day, a certain number of eggs wake up. Most of them wake up and die. And once they've all woken up and died, menopause, you're pretty much done. And apparently, there's some intriguing data to suggest that women can take this medicine and have fewer eggs wake up every day, and that might slow down the egg loss. Instead of losing eggs like this, maybe you can lose eggs a little slower. I'm just hearing about it. I don't know any data, but certainly you're talking to resveratrol and all these other medications and whatnot. Maybe rapamycin's kind of in its heyday of excitement here, because apparently I won't get into all the purported benefits. It lowers some inflammation, et cetera, maybe increases healing and whatnot. Do you have any thoughts on rapamycin?
Yeah, I think it's interesting that rapamycin it's an immunosuppressant, and so
used for prevent rejection after organ transplant, I believe.
Right. In medicine, I don't think we use these. What actually gets used are these medicines that are kind of related to rapamycin, the sirolimus, tacrolimus, and I think they're cousins, or rapamycin, very similar. And so, some of the data from rapamycin, or that it kind of gets extrapolated to rapamycin, I think they kind of use from those medicines. But I think it's been a while since I read about it, but the rapamycin medicine, I think it was one of these, again, this Dr. Sinclair from Harvard, I think he also did a study on mice and showed that the rapamycin...
The mice lived longer.
Yeah, mice lived longer with the rapamycin as well. And so I know I've seen online some people, I think some are actually kind of self-experimenting and taking rapamycin themselves.
People are. I believe it's generic now. I don't think it's too expensive. There's an oral form. It's not a controlled substance,
Sure.
So, I think there's a lot of experimenting going on. Back in the 70s, it was BHA, BHT. There's the preservatives you find in food. Well, there are people purporting that, hey, take these preservatives and maybe you'll age slower.
Wow.
Yeah, so things come and go. But, is this one is it a more valid, thing to do?
Yeah. Yeah, it's I like the medicine rapamycin. It's interesting to me. I just, you get into the cell biology of it and the molecular biology of it, the mTOR pathway, or the molecular targets of rapamycin. It's a kind of a major regulator of the entire cell and how it works. And so it's interesting that these medicines that really started as just a basic science way to kind of manipulate cells in the lab end up having all these different downstream uses later on in the world.
So the story's still being written on rapamycin.
Yeah.
So, so no bombshells there, but we both await more data. And hopefully we'll get that data before we die, before the singularity.
Sure.
Right. That's a whole nother talk about immortality. Is would you do it if you could be, right?
I wonder if that would be possible. You think about do you think do you think consciousness could be, uploaded into a computer and it would still be you?
Yeah, right. I don't. I
don't think it
We'll
could.
talk about maybe in fact there are quantum effects, and maybe consciousness is an entanglement phenomenon and stuff. But that gets into a whole other world of quantum physics and whatnot. So, Joe, as we wrap this up, we've been talking now about an hour. Are there any other topics in medicine that you would like to chat? I know you have a particular interest in sepsis, which is infection in the blood. I know you've got other interests. Are there other things you want to talk about, or do you want to come back for another visit?
Well, I'd love to come back for another visit, but you mentioned sepsis. I'll just talk about it for a second. You know,
Sure.
as a internist that treats people in the hospital, I feel like if there's one thing I'm could be a specialist at, so to speak, it would be treating sepsis. You know,
All right.
really,
And a bad infection of the whole body.
right. And so what happens, in getting back to this public navigation of medicine, can be a lot of confusion of patients, or a lot of misunderstanding in regards to sepsis. And what I find happening a lot of times is when I see somebody or a patient's family member, and I'm describing to them that, Mr. So-and-so has sepsis, you know, there's an infection in their leg. You know, oftentimes there's the kind of this taken aback, like, oh, sepsis, you know, that's really bad, isn't it? And so sepsis is a very serious thing, but at the same time, 80% of the people that I treat in the hospital, they get admitted because they have sepsis. It's a very treatable thing. Is what I try to get across to people, is that it's not a death sentence per se. You know, I think
that's good to know.
I think that's what oftentimes patients feel like when I say that word. You know,
because you can die of sepsis.
Well, you can, yes.
And that UTI can become
yes.
urosepsis
Yes.
and kill grandma.
There is significant morbidity and mortality associated with sepsis, but at the same time, like I said, about 80% of the people I treat in the hospital have sepsis one way or another. So the point I try to get across to patients is, yes, this is serious, but at the same time, this is a very treatable thing that, you know, antibiotics are very good at treating, you know. So sepsis is really, what I tell patients is it's kind of a loaded term. And really, you know, sepsis, the way we use it clinically, really all it means is you have your vital signs in your labs look in such a way that you meet criteria for sepsis. And I tell people, if I take a brisk walk down the hallway, technically I would meet criteria for sepsis because my heart rate's a little bit elevated and I'm breathing a little bit faster. So,
well, tell Joe, what are the criteria to make a diagnosis of sepsis then? That's very interesting.
Yeah. There's a few different criteria for sepsis, and that can be kind of a hotly debated area of medicine. And, you know, some of these criteria kind of have a higher sensitivity, or some of these different criteria have a higher specificity, so you can kind of use whichever criteria that fits your kind of area of the hospital.
And let me explain that real quickly. Sensitivity is the chance of saying that somebody does have it. What is the probability they have it? And specificity is saying what's the reliability that you can say they don't have it.
Yeah. And so I think, you know, in the hospital I work at, you know, the criteria we use, it has a little bit higher sensitivity. And so the idea behind that is that it's going to maybe have a few false positives, but at the same time, you're not going to be missing anybody.
Right. You'd rather overtreat a little bit than undertreat and have somebody die. And it looks like you undertreated them. It doesn't look good.
Right. And so the criteria that we have, you know, it's really is your heart rate above. You have to have two of these 4 or 5 criteria: heart rate above 90, respiratory rate above 20, temperature above 100.4 or below 36.5.
Or below. So a low temperature can occur with sepsis.
Yep.
And nowhere have you talked about bacteria in the blood.
Right. Exactly. So
I don't see any bacteria in the blood there, Joe.
So
in these criteria,
so that's a whole separate thing. You know, kind of we call that bacteremia, sometimes septicemia. You know, you can have bacteria in the blood, but you know, having sepsis doesn't necessarily mean you have bacteria in the blood. It's really about these cytokines and these inflammatory mediators. The example I give people is like if you cut your hand and then, you know, you notice there was redness and swelling around the cut. You know, that cut in your hand, that redness and the swelling is mediated by these things called cytokines. And that's really what ramps up your immune system and tells your immune system, hey, we need to go to this area because there could be an infection or something brewing here and we need to protect it. So now sepsis is kind of that, not just that cut, but it's that redness and swelling happening throughout your entire body. And that's what causes these vital sign changes. And that's what can cause it to be so dangerous, is because these cytokines cause us to have respiratory failure, or cause us to have cause us to have heart failure because of losing fluid and into our third spacing of fluids in our body. So it's a very complex thing, and essentially that's the point I try to get across to patients. They get very concerned about it, and I try to tell them, yes, it's a serious thing, but it's very treatable. Like I said, 80% of the people I see in the hospital meet criteria for sepsis. That's what I treat, and we're pretty good at it. So
great. And I'll just add on that I deal with tumors and cysts all the time, the vast majority of which are benign, treatable, nothing to get scared about.
Yeah.
So you hear the word tumor, don't think that's not a death sentence either.
Yeah.
Something we know how to work with. Well, Joe, what a fun, wide-ranging discussion we've had today. Let's have you back sometime. We'll talk about some other things that are of interest to you that we can drill down into deeper. Once again, thank you for your time. Thank you for being my friend and my colleague here in mid-Missouri. And it was a real pleasure talking to you today.
Yeah, same to you, Gil.
Thank you, my
It was
friend.
great. Thank you.